Senator Cassidy.
Thank you all. Ms. Nicolai, again, incredibly moving testimony. And unfortunately, we all have an experience similar to that. One thing you said, though, that I, as a physician, my ears perk up, that one of the young men had been hospitalized or in the ER 7 different times and family never notified. And I think, for the record, that is a misunderstanding of HIPAA laws. That is HIPAA, which normally has confidentiality requirements, but I was trying to double check, but I was specifically told yesterday by someone in a position to know that HIPAA does allow someone to call the family of somebody in an overdose and to inform them that they've been. Any comment on that?
You are absolutely correct. We actually have drafted a memo for councils at hospitals to fully explain that this is an allowable activity to notify a family, to notify healthcare providers after a non-fatal overdose, and we need to change a lot of the practices. How we respond to non-fatal overdoses in this country is the most important and one of the first things we should be doing. Of the nearly 64,000 people that we're losing annually to overdoses, 70% of them had a previous non-fatal overdose.
So let me just interrupt.
Yeah. Well, let me interrupt just a moment without taking your time, Senator Cassidy. Would it be a good idea to include in our legislation any language that would make it clearer, the point that you're making, so hospital and their councils would know that?
I was about to just ask you and the ranking member if we could do something like that. When I was on Energy and Commerce Committee, we once had a panel of HIPAA experts, and they were disagreeing with each other to the degree to which you could share with somebody. And I can tell you, if you're the ER physician at 3 in the morning, you've got 10 people waiting, and your default is to not share information. So the degree to which we can promulgate that, ideally put a tattoo on somebody's head, say, look, oh yeah, I remember that now, we will be doing an incredible service. So.
Why don't we first not deduct from your time for my interruption, and second, why don't Senator Murray and I work with you, and if the witnesses would like to provide us with suggestions about how to do that. We respect the HIPAA law, but I think it's not just overdoses, it's emergencies. Yeah. Where families can be notified, but people are afraid to do that.
That would be
Senator
wonderful.
Cassidy, if you would work on that,
yes,
that would be very helpful.
Next, again, thank you all. My office has kind of initiated something we called Safer Families and Healthier Communities. Ms. Donahue, you seem to be plugged into that. Indeed, the people you're serving, those children born of parents addicted, is kind of the beginning of Ms. Nichols' testimony. You're acquiring all this great data. Can I ask what you are doing with that data?
Yes, so in our database, we are tracking maternal characteristics, such as where that particular woman resides. We are tracking what type of substance.
Try and speak quickly because I have limited time.
Sorry. We are tracking what type of substance is involved and whether or not the particular mother has prior substance-exposed infants.
So with that data, can
yes.
you then say, okay, we know this child is born to a mother who is addicted, therefore we are going to proactively send support out there?
That's correct.
Now, you imply that there is, one, federal resources that enabled you to begin, but a lack of resources in which to fully go to scale and or continue. Is that true?
Especially with the plans of safe care, yes.
Okay, now there was in 21st Century Cures a lot of money which apparently has had a hard time getting out to the states. Is it just that this money hasn't gotten out, or that money which is even allocated will not be adequate?
We've actually seen some of the benefits of the Cures Act through peer recovery coaches through our Delaware chapter of SAMHSA. So the peer recovery coaches are actually being utilized in some of our substance use treatment disorder centers, including the medication assistance treatment for pregnant women. And the peer recovery coaches have been fabulous.
So there is getting there, but perhaps not for this particular program.
Correct.
Ms. Nichols, quickly, I think we have a shared interest in what we can do to improve access to addiction treatment medicine. One thing I'll again point out, some addicts after their recovery from an overdose really don't want to be treated. They want to take another hit. So the issue is, can we give them some sort of long-acting drug that if they go take another hit, that'll be kind of, oh my gosh, I don't want to do that again. Any comments quickly on that?
We do have new long-acting formulations of medication-assisted treatment, and I think we need to clear some barriers to making that new medication available to our patients. I believe this committee worked on some language to help with that in S916, I believe.
Yeah, my bill, I love it.
Yeah, good. Thank you for that. But I think as we have advancements in medications, we need to make sure we can actually get those medicines to our patients.
Yes, and this is, that one provision I'm not sure is in the final version so far, but just to say long-acting, again, to my colleagues, sometimes someone takes an overdose and all they want is another hit.
Well, you wake up in active withdrawal, so you're having your worst day and feel crappy. The quickest way to fix that is to use again, or to get someone connected.
But these
to treatment.
long-acting preventions will be something which,
Exactly. They
which
can
will
mitigate.
then, although you're within withdrawal, you won't go back so immediately and hopefully get into recovery.
Absolutely.
Mr. Morrison, I had a question for you on accountability, but I'm almost out of time, so I'm going to yield back. But I am interested for a question for the record. These programs that we're doing, we're interested in evaluating to make sure that they work. It's just not a place to send federal dollars. So the question for the record you'll receive is, how do we consistently have outcome measures which tell us what we should do or perhaps what we should not do? Thank you all for your good work.
I stole at least a minute from you, so if you want to pursue that, please do.
Because we're interested in that accountability, and I know there's some people who just make money off of government contracts. And I do that because I used to work for the government. But there's others who actually use it to good end. How do we have that accountability measure to know these programs are working well?
Sure, we work with SAMHSA on looking at different measures regarding the use of alcohol, the use of drugs, the impact of treatment on employment, the impact of treatment on criminal justice involvement, and then connectiveness back with the society. So we're eager and actually embrace.
Do those measures work? I mean, sure, you're doing them. Do they work?
Well, they're helpful, and we also would benefit from additional resources to look at long-term studies, looking at post-discharge 6, 12
I'm
months.
a minute over. I'll stop. But our QFR will ask you to put a finer point on that answer.
Look forward to it, sir.
Thank you,